Hey there. Good evening, everybody, and welcome. Guess what time it is? It's 4 o'clock in the mountains, which means 6 o'clock on the East Coast and three on the West, five in the Central. And it is time for Fertility with Fink and Friends. I am Fink, and you are friends. And as we are every Tuesday evening at this time, it is great to be with you live from Colorado Springs, where I am the clinical director of IVF services here at CNY Fertility Colorado. And we do this every week. We kind of get together, hang out, talk about things that are important to all of us, things about your body, your lives, your health, and making your families, because that's what we do here. It's my favorite place to be. And gosh, this is a very momentous night, election night, 2024. Hope you all had a chance to get out and go vote in Colorado. The majority of the voting is mail-in. And so to me, I was actually just saying today that, gosh, it would be so stressful to have to go be at the polling place today, because they're talking about make sure that you get out and vote. This is the most important, election of our lives. And every election is the most important election of our lives, And nice to have voted in advance, but we'll all be sitting by the televisions watching what happens over the next few days. I try not to be, too involved with the politics of things, because, there's so many different opinions out there about what's right and what's not. I'm certainly, concerned about women's rights and about IVF and the accessibility to healthcare for women. But I would say that, the one thing that I really want to harp on here, and it's not really political, but it goes back to that nice sign behind me, the one on top, the round one that says kindness, love, and hope. There's not enough kindness in our world now. And why is that? In my opinion, I think it has a lot to do with what we see our politicians doing and how we see our politicians treating each other and other people. The kind of combative language that comes out of, it doesn't matter which party you're talking about. It's just there, and it normalizes that bad behavior, that somehow or another people have learned that it's okay to treat other people that way. And so my word tonight is, if we are going to be voting, I suggest that we all vote to be happier, that we all vote to get along better, to lead every step forward with kindness and love, because that's what makes the world a better place. It's not about a political party and their own beliefs. It's not about a candidate, because there is never going to be a candidate that we can all fully embrace on 100%. It's about making the world a better place. So here's hoping that the next 4 years bring us to a happier place in our country. And that is my wish for everyone. So let's say hello to all our friends who have joined us here. We've got some folks on Facebook and YouTube over here. Hello to Rachel, who can't wait for her first appointment. And Dr. Anedra Marie Johnson is having her transfer tomorrow morning in Sarasota. Good luck to you, my friend there. We've got two different Instagram feeds here. We've got my Instagram, Randy Fink MD, and we've got CNY Fertility right over here. And so let's see who we have joining us. H.U., you are the first to join. Thank you so much for being here, Nessie and Mimarut. Leah Schmink, hello, my friend, and Brandis, our wonderful nurse practitioner here at CNY Fertility Colorado. A special hello. Thank you for being here. I am old soul. I like it. Hey to Michelle Marks and Jenny Thinks. Thanks for saying hello. Tara Whitmarsh, nice to see you as well. Hello to Zaneta in Miami. Mariah Wagner. And Mrs. Vince. Oh, we have the honor of having Amber Vince with us tonight from Kentucky, and her beautiful baby, I hope, is probably not too far away. Looking suave today. Well, thank you very much. You mean these spectacles? I keep trying to change it up because, again, you can't see my socks. All you see is like my collar and higher. So I've got to change glasses just to kind of keep you on your toes. Let's see. Shada, nice to see you as well. I've got to talk to you, by the way. way. Okay, so let's see who we have over here on the CNY side. First to join was Rosa SD. Thank you for being here, Rosa. Forever Sonia, nice to see you. Witchy Bliss, Antonetta. Boy, this is like my small little phone. I'm trying to look here when I'm having a hard time seeing my journey with IVF. Just D1 and only. Hello to you, my friend. Let's see. I also wanted to say hi to, I saw Angelina. Hello, my favorite nurse practitioner in Minnesota. Thanks for being here. Okay, so now, what do we got here question-wise? First comes from H2. What would be your protocol for someone with egg quality issues who has polycystic ovarian syndrome? So we've got two separate issues going on there. People with polycystic ovarian syndrome typically will respond very well to medication. That medication, the stimulation medication, if we're not careful, can get you to hyper-stimulate or to overproduce your eggs. And we don't want that to happen, because when your body is more into making eggs, you produce quantity over quality. And so usually in folks with polycystic ovarian syndrome, we dial down the dosage so that we can get you to make fewer eggs, but really better eggs. As it pertains to what can we do for egg quality, there are some different things that we focus on. Here we'll look at things like omnitrope, adding on human growth hormone. Growth hormone is what keeps us young. And so if we add some growth hormone, that may help your body to repair some of your own age-damaged DNA. So that's a good thing. We can do a little priming beforehand. There is a protocol for embryo quality, or rather for egg quality. There's a handful of supplements that we can take that are associated with improving our egg quality or IVF outcomes. Those, by the way, are available through, if you go to my Instagram page, Randy Fink MD, and click on the link in my bio. It's my link tree, and that's linktree/Randy Fink MD. I wrote a book called The Vitamin Victory, and you can see where we outline that. It's a $7 ebook, and that includes a coupon that'll get you probably about $25 off the purchase of the vitamins in that protocol. So I would suggest taking a look at those things. Shada says, does Orilissa stop your period, and how long after stopping Orilissa would endometriosis come back? So we use Orilissa to suppress endometriosis prior to doing an embryo transfer. Why do we do that? Because the presence of the inflammatory marker in the lining of the uterus called BCL6 can very substantially decrease the success of an embryo transfer. So we know that by taking medication for 60 days, we can decrease the presence of that BCL6 and improve those pregnancy outcomes really back to what it would be like if there was no endometriosis involved at all. So 60 days of Orilissa will do that. Will it stop your period? In most cases, yes, but not in all cases. How long after stopping would you expect that marker to return? They really haven't studied that, Shada, to be honest with you. And so I can't say for sure. I've heard some people say 3 months. I've heard other people say, well, you can probably really take 6 to 9 months or even 9 to 12 months after suppressing before you would expect that marker to come back. I'm Old Soul is 0.872 in AMH, decent for someone who's 40 years old. So that would still be considered when we have an AMH that's less than 1. AMH is the anti-Mullerian hormone, and that is the measure of our ovarian reserve. When we have an AMH of less than 1, we generally consider that diminished ovarian reserve. Now, that's not especially abnormal for someone who is 40 years old. Is that a good number? Well, I would rather see it be 1.5, but that's certainly by no means a bad number. So I think that you have the potential at 40 years old to do very well with fertility treatment, IVF in particular, with an AMH of 0.872. And that's my 2 cents worth on the matter. Going back to that question about Orilissa, a follow-up there, if the first transfer doesn't work, do we need to do another suppression prior to the next FET? And I would say no. No, generally, there's no evidence to suggest that you do need to do that because, again, that first 60 days of treatment will probably have a lasting impact on the uterine lining. How long necessarily? Hopefully, certainly long enough for you to be able to get pregnant and not to have to do another round of suppression. Headed back over to the CNY side, Forever Sonia says, I'm going to take my glasses off so maybe I can see a little better here. Does not taking Omnitrope affect my IVF process? No, not at all. And I would say, there is some controversy as it pertains to the Omnitrope medication. What is that controversy? Well, there are some studies that show Omnitrope doesn't add anything to IVF. In my experience, I believe it does make a difference, particularly in those with a lower ovarian reserve in whom we will expect to have a lower egg quality, or for someone who has been through a cycle and has demonstrated that there is an issue with egg quality. I think it does make a difference, but not being on it is absolutely not a deal breaker under any circumstance, but especially if we don't know necessarily that you need it. Does that make sense? Rosa SD, how often do you see Orilissa working in advanced endometriosis? I see it work, all the time, every single day. So the options for treating endometriosis are Lupron. Lupron is the medication that we had going back, probably 35 years. Maybe about 7-8 years ago, the oral medications came out, and that's Orilissa and Myfembree. Even though Lupron has a tremendous amount of data behind it because it's been around for so long, Lupron shuts off all the hormones. Lupron pulls the plug, turns off the switch, makes everything go dark. So really what it's doing, even though it's only for a temporary fixture, Lupron's putting you into temporary menopause. Now, for this, we're doing this for 60 days, and then your hormones will return to normal. And we can always manage the side effects that go along with the hormone withdrawal using Lupron. However, Orilissa is just better tolerated. So we do have options. How often do I see it work? Literally every single day. We know that treating can take that BCL6 marker and turn it to negative within that 60-day period. And then your odds for success go absolutely back to where they would be if you didn't have endometriosis. Let's see. What's the preferred time in the cycle to start Orilissa? You can really start it any day. Do you need to wait until your period to start Orilissa? And the answer is no, because it's going to start to suppress you no matter where you are in your cycle. But if you started at the beginning of the cycle, you are less likely to have irregular bleeding. So that's the only caveat. I would say as soon as you get your hands on it, go ahead and start on it, because the quicker you start, the quicker you'll be done. Creole Chantel says, yes, vote 2024. Melissa says, what can I do to prepare for my second egg retrieval for better results? Well, so again, there are a list of supplements that I recommend everyone be on for egg quality, whether you have a normal AMH, whether you have a diminished ovarian reserve, whether you are going to do an embryo transfer, whether you're doing IUI, or whether you're just trying at home. This list, there's another wonderful book. It starts with the egg. Of course, I think my book is better, but mine's certainly cheaper. Very good evidence that taking supplements can really help. How can you get that? My link tree, that's linktree/Randy Fink MD, or see the bio on my Instagram page, which is Randy Fink MD. Click the link, and you'll see where that is. That's probably the most important thing that you can do in advance. Now, there are some other things, and I would say, I like to see back-to-back cycles. You know what a back-to-back cycle is? That's also what we call stacked cycles. And stacking cycles is where you do your IVF one after the other. So let's say you do your retrieval, and then 10, 14 days later, you'll get a period. You get your period and you start on your next stimulation. Why? That's a stacked cycle or a back-to-back cycle. Why would we want to do that? We would want to do that because the medication that you use in the first cycle will continue to help you recruit eggs in the next cycle. And so the data shows us that each successive cycle gives us better and better results in most people. Now, it may not dramatically increase the number of eggs that you get, but it should improve the egg quality. A stacked cycle, I think, is very important, and to the extent that you're able to, 100%, I do recommend it. Let's see. Looks like Barbarit says, at the age of 38, PGT testing. So PGT is pre-implantation genetic testing for aneuploidy. And what does that mean? Well, when we do an embryo transfer and someone does not get pregnant, the most common reason that happens is because there is a chromosomal or a genetic issue with the embryo itself. So if we have a large group of embryos, we can test them to see which are the group that are believed to be chromosomally normal. And when we know that they're chromosomally normal, they have a greater probability of getting us pregnant. So the benefit to doing PGT testing is that we're able to separate out the group that have the greater probability of getting us pregnant. Now, there are some people who think, well, because of my age, I have to do PGT because we want to have a normal baby. And I say, oh, you're one of those people that wants a normal baby. Well, I don't know about that. We all want normal babies, but PGT testing is not to give you a normal baby. It's to identify the cohort of embryos that have the highest probability of being normal, and so therefore have the greatest chance of getting you the positive pregnancy test. The group in whom it has been shown to positively affect live birth rates is typically women between 35 and 40. So at 38, yeah, I think it's a good idea. But it also depends on how many follicles you're growing, how many eggs you have. Because let's say that you have, let's say that you make 2 eggs and you get 2 embryos. Well, with 2 embryos, I would not recommend PGT testing because you could transfer both those embryos into your body, and they're either going to stick because they're normal or they're not because they're not. If you have 10 embryos, then it makes sense. Yeah, let's do that PGT testing so that we can go from these 10 embryos to these 5 embryos that are the ones believed to be normal. And so these 5 are the ones that are going to give us the greatest possibility of pregnancy. So it may mean 5 fewer unsuccessful transfers. And that's really where I think its value lies. Let's say, by the way, if you're just joining 20 minutes after the hour, I am Fink, you are Friends, and this is Fertility with Fink and Friends. As the sign says, if you're on Instagram, then you're looking at that backwards. However, my friends on Facebook and YouTube can see it the front way there. A beautiful sign. And I love having it there because it makes me happy. And if you're not aware, it is all about my happiness, right? As long as we're all clear on that. Okay, let's say hi to some more friends over here on the Facebook side. We got a bunch of questions over there. Hi to Olivia and Leanne. Leanne said, I had my egg retrieval with you on 10/24. You were amazing. Oh, gosh, you say all the right things. Can't wait for transfer. Well, can't wait to get your Christmas card with the picture of all your kids. How about that? Hi to Leanna Wynn. Does a transfer after a uterine septum resection have a good chance? And I would say, yes, it probably does. So a uterine septum is a muscular band that runs down the middle of the uterus. And so it makes the uterus literally look like a little, kind of Valentine's heart. Oh, look, it's like Instagram is making, it says it sees me doing this and it's making little hearts. I don't know if you could see that, but that's very cute. All right. It's the little things that keep me happy here. So a septum is that muscular band right there. So there are some folks who have recurrent implantation failure or recurrent pregnancy loss, and we find that they have a septum in the uterus. In that scenario, the classic wisdom has been that we want to resect, we want to remove that band of muscle in the uterus to improve outcomes. There was recently a big study that looked at, well, how necessary is that? What happens to the outcomes when you remove or don't remove? And in the general population, it's what they'll say, it's a shared responsibility model, which means basically it's up to you whether we do it or not. Basically, doctor make a recommendation and it's up to you whether to follow it. And that goes to say that the presence of that septum may cause problems, but then again, it may not. If you've never had an embryo transfer or a pregnancy failure or any issue at all with getting pregnant, then and you happen to find a septum, there is no evidence that it needs to be removed. That's really, I think, what the study showed us. In my opinion, in the fertility population, when I find a septum, usually I do recommend that we remove it. It's a very straightforward procedure for us to do under a little sedation in the operating room. Basically, it's just a band of muscle, and all we do is just kind of cut through it in the right hands and experienced hands. That is a very, very simple procedure to do. So, yes, I do think after that resection, Leanna, your odds will improve. Nicole Decker is here on the Facebook side. Can you please help me understand the HSG and the sonohysterogram? Absolutely. So an HSG is a hysterosalpingogram. Hystero means uterus. The salpinges are the fallopian tubes. And so with an HSG, we place a little tube inside the cervix and place a teaspoon of fluid inside the uterine cavity while taking some special type of X-ray pictures. And what that test shows us is that your fallopian tubes are open. When we're trying to get pregnant in the normal way, we need for those fallopian tubes to be open, right? Because that's the highway by which sperm meets egg. So we want to see that the tubes are open. It also shows us the general shape of the uterus. Now we've put that fluid inside. So then once we're done taking the x-rays, if we place a vaginal ultrasound inside, and that's what a sonohysterogram is, we can see really what the uterine cavity looks like to make sure there's not any small abnormalities like polyps or little bands of scar tissue or other issues that may prevent an embryo from being able to implant on the inside. When we do those, we typically do the HSG and the saline sonogram together. The HSG followed immediately by the saline sonogram. In my opinion, if you are doing IVF, you do not need to do an HSG. Why is that? Well, some people believe that, so there is a condition that can happen in the fallopian tubes, and that's called a hydrosalpinx. A hydrosalpinx is fluid that fills the fallopian tube, and that fluid is toxic to embryos. So we don't want that fluid to be there. Now, any truly significant hydrosalpinx should be able to get recognized by ultrasound. There are some people who feel like, no, you can only see a hydrosalpinx by HSG. And so if you're going to have IVF, we want to make sure that you don't have a hydrosalpinx. However, the kind of Bible that we follow, which is written by a doctor by the name of Spiroff, Dr. Spiroff wrote the book on reproductive endocrinology and infertility. And even in that book, it says that the HSG is not the test of choice for a hydrosalpinx. And so in my opinion, if you're going to be doing IVF, I don't need you to do an HSG. However, if you're going to be doing IVF, For sure, I want you evaluating your uterine cavity because we don't want to invest in making beautiful embryos and not knowing that the environment that those embryos are going to go back inside is just as beautiful and just as perfect as that embryo itself. So you can do that with a freestanding saline sonogram alone, and that can often be done in your own OBGYN's office. And it's done in a similar fashion. We place a little catheter in the cervix, inject about a teaspoon of fluid inside the uterine cavity while doing a vaginal ultrasound. Gives us a tremendous amount of information. So that's the difference between the HSG and the sonohysterogram. Andrea Kimstat says, what are the best treatment options to prepare my uterus and follicles while dealing with Hashimoto's? Hashimoto's is autoimmune thyroiditis. The thyroid gland lives here in your neck, and some of us develop an antibody against our own thyroid gland. And in that situation, we there's some things that we like to do. Basically, what it's saying is that you've got an autoimmune situation. It means that your body has mounted an immune response against your own thyroid gland. So, given that, we will probably step up one of our immune protocols to make sure that we're getting those bases covered. Now, if you're not imminently trying to get pregnant and you're known to have Hashimoto's, sometimes we will treat that because it can make you not feel well. In the practice of functional medicine, I generally will treat Hashimoto's using something called desiccated thyroid. In the fertility world, we typically use levothyroxine, which is a synthetic version of thyroid. So we like to make sure that the thyroid gland itself is tuned up and is where it needs to be. But you can also use a vitamin with extra selenium. Selenium is a supplement that is said to be helpful in thyroid support, especially for those with Hashimoto's disease. Dr. Anadra says, thanks for explaining stems for PCOS. My first egg retrieval resulted in 24 fertilized eggs and 7 embryos. This egg retrieval had 7 fertilized, 7 embryos. I was worried about the low numbers. Well, like I say, that's the reason that we want to lower that stem down so that we can, fewer eggs, but better quality eggs. So glad to hear that. Leanne Castning says, in a second egg retrieval close in proximity to the first, is that known to yield more mature eggs? So maturity of the eggs really probably has to do with a bunch of things. It kind of depends on how mature were those follicles when you were triggered. So that's the first thing I would look at if we had a large number of eggs that were immature. But I would expect that your egg quality is going to go up as you increase, as you stack those cycles. Yeah, for sure. Back over to my side here on the Instagram side as we are at 30 minutes past the hour. By the way, a special hello to the Bama Gal and to Mom and Dad sitting watching in on YouTube there in Mobile, Alabama. Thank you so much for being here as always. By the way, folks, if I didn't tell you this before, I've said this before, but I'm going to say it again. Pick up the phone, call your parents. Call your parents. If you've got them, love them. It's great to have them around. If you haven't talked to them lately, just call to say hello. That's all you have to do. Mariah Wagner says, I don't understand the percentage of pregnancy increasing with each transfer. I keep seeing that by the third transfer, your chances are better statistically. Can you explain? Yes. So when we look at euploid embryos, and that is the embryos that have been tested and that we know are chromosomally normal, your first euploid embryo gives you a 65% probability of pregnancy. So if you test your embryos, 65% is the probability of walking away with positive pregnancy test if you have a tested normal embryo. Well, each embryo, really truthfully, as an individual statistical event, is at 65%. Now, a lot of times I will talk to people after they've done a euploid embryo transfer and they cannot understand why they didn't get pregnant. They had a euploid embryo. They're supposed to get pregnant. Why didn't it happen? Because 65% is not 100%, right? It doesn't always work. But what happens if you take a 65% and then you add another 65%? Well, 65 and 65 is 130 if I'm doing my math right, and that doesn't make any sense. You can't have a 130% probability of pregnancy. So you start to get some diminishing returns with additional embryos, even though the overall pregnancy rate goes up. So by the time you're on euploid embryo number 2, you have an 88% probability of pregnancy. So 65 to 88% by euploid embryo number 2. And that's because you can't have 130%. And then when you add embryo number 3, you're at a 95% probability of pregnancy. And that's really just because of the additive property of how those the statistics work with that, that you can't have a possibility that's greater than 100. And really, it's unrealistic to think that you would have a possibility that is even 100. But so as you add successive good quality embryos, meaning euploid embryos, your chance of pregnancy goes up. And that's kind of how we think about those numbers. 65%, 88%, and ultimately 95% by embryo number 3. Now, that said, in my opinion, if you have done 2 euploid transfers and you have not gotten pregnant, you need to be talking with one of us because we want to make sure that we're dotting all the I's and crossing all the T's, that there's nothing that's missing there that we might be missing that could be preventing you from getting pregnant, because these euploid embryos are highly sought after. They're very precious. And so don't transfer another embryo until we know that it's all good. Hi to Chris Botto in Miami. Thank you for being here. Oh, my Glinda is watching from Las Vegas. Thank you for being here this evening. Let's see. Bubbles post. I had a failed FET and then got pregnant naturally. Yep, I have adenomyosis and endometriosis, but had downregulated before the transfer. Should I still take low-dose naltrexone during my natural pregnancy? So there is no evidence to show that low-dose naltrexone is necessary in your natural pregnancy. Low-dose naltrexone is one of the medications we use on our immune protocol. And what does it do? It increases your endorphin levels, and that ultimately has a positive effect on your fertility. But should you be taking it during pregnancy? Well, I'm not sure how really well studied it is in pregnancy. Probably not so much. So I would say you got pregnant. This is fabulous. Maybe after the first trimester, after you pass that 12-week mark, when the risk of spontaneous miscarriage goes down to less than 1%, I would think about stopping the low-dose naltrexone. Now, there are some who say, absolutely not. You can stay on low-dose naltrexone. It's not harmful. In the anti-aging world, there are people who will be on low-dose naltrexone for years and years and years. And in fact, the longer you're on it, really, it has an amazing effect on the immune system. Like people never get sick. You never catch a cold while everybody else is getting the flu. You're completely normal. So there may be some reason to stay on it, but my recommendation is I think you're fine to stop it. Wait until 12 weeks. Excuse me. Mrs. E. Villarreal says my acupuncturist thinks my baseline thickness was too thick. Okay, well, acupuncturists are not commonly also gynecologists, excuse me. But can it be too thick? It was a little over 5. 5 is perfect. That's really where I would expect you to be at the beginning of a cycle. No, I do not think that is too thick at all. Leah Schmink says, after an infertility summer off, pardon me, gearing up for another transfer, what's the lowest amount of estrogen you can use for a medicated transfer? Well, so typically for the standard recipe for medicated transfer is going to be 2 milligrams of estradiol by mouth. Excuse me. I am all choked up, Leah. Look at what you've done to me. You ask me questions about estrogen and the world falls apart. It's because I was talking about low-dose naltrexone and how it keeps you healthy. My son is sick at home, and I think this is what he did to me. So, if in doubt, blame your child. Yes. So typically, estradiol is going to be twice a day orally and 3 times a day vaginally. That's usually what we do because we're working very hard to get that lining thick. Over on the CNY side, for remote monitoring patients going with an FET in the Colorado office, do we get any doctor's input or is it solely managed by travel nurses? So if you are monitoring outside and you're being taken care of by the travel team, not only do you have the expertise of the travel nurses, but there are also providers that are on that travel team. So if there's ever any questions, they are always available to get an answer. And certainly, if there is anything that you're not sure about and you would like the question of the doctor, you can always feel free to ask the travel team, hey, can you please run this past Dr. X, Dr. Fink? Can you run this past Brandis? Can you run this past Dr. Didkoff? Can you? Anytime, we're always happy to do that. And we get those kinds of questions really all day, every day. So awesome. Hi to Pamela Hodgkins and hello to Just D. What can I do to prepare myself for the next transfer? The fluid in my uterus was found during my last transfer. For that transfer, there was a little fluid and it was aspirated and we proceeded. So as long as it's as you can remove it, then that's fine. So fluid inside the uterus may be something that's left over if you did an HCG or a PRP wash. But if it's just there on its own, then that fluid usually represents some inflammation. Think about if you fell and skinned your knee or your elbow and it gets kind of wet and icky and gross, as you get that road rash on it. And that's kind of what's happening inside the uterine cavity. Oftentimes, some Mucinex will also help that to go away. So it depends, if we see that in the clinic leading up to transfer, we may suggest that you go on Mucinex, and that's the reason why. Let's see, Ashley and company, I'm 19 weeks pregnant and you did my retrieval in July. Woohoo! Thank you very much. Glad to hear it. When can I get pregnant again after this C-section? My friend, you are barely halfway through your pregnancy and you are already planning on your next transfer. I take my hat off to you. You're good. Oh yeah, you're good there. So if you're having a C-section, I generally personally recommend a minimum of 9 months recovery before doing another embryo transfer. So you're having a C-section, so I'm guessing that is a repeat C-section. You had one before. Folks nowadays do have the opportunity to be able to choose to have a primary C-section, to choose to deliver by C-section, but I'm guessing, Ashley, that this was will be a scheduled repeat for you. The muscle of the uterus is delicate. And once it's been damaged by cutting into it in order to get the baby out, when it heals, it doesn't heal with the same strength that it originally had. So think about it this way. Your bicep muscle here. The bicep muscle that's supposed to be there anyway. So let's say that you could lift 100 pounds with that bicep muscle, that muscle was strong enough for 100 pounds. And then we cut into it and did something to it for whatever reason. And then that muscle healed up. We sewed it back together and it healed up. Well, when it heals up, fully healed, it will then only be able to lift 80 pounds. You lose about 20% of the strength of that muscle from the C-section. So we really want to make sure that muscle is well healed before another pregnancy goes inside, because that muscle does everything. It keeps the baby safe. It keeps the uterus closed, and it allows the placenta to implant so that the blood flow can go through. There are some who say a year after a C-section, but I think the data that I've seen is that 9 months is sufficient. And part of that will also depend on what your OB says about the shape of your uterus, because there are some people at the time of the C-section where that area that we make the incision in, which is called the lower uterine segment, has become paper thin. And if it's so thinned out that it's just one little layer of cells that's keeping that uterus together, well, then it may be that you need a little bit more time to try to recover before doing another transfer. Lacey over them, would you transfer one euploid and one mosaic together? Generally, no, I would not. So the recommendation with euploid embryos is that you transfer one euploid embryo. Now, there is nothing wrong with a mosaic embryo. And we've talked before about mosaic, but let me just throw in a little bit for those of you who aren't familiar. What is a mosaic embryo? Well, you know that we have two sets of 23 chromosomes, or we have 46 chromosomes. A mosaic is when some portion of one set of those chromosomes is believed to be abnormal based on the biopsy that's done of the portion of the embryo that becomes the placenta, also known as the trophectoderm. That's a mosaic. What we know about mosaics is that they're not throwaway embryos. So a euploid embryo gives you a 65% probability of pregnancy. Depending on your age, an untested blastocyst can give you up to a 40% probability of pregnancy, especially if you're 35 and under. 40% would be the number that we would quote. Well, that mosaic embryo can give you a 45% probability of pregnancy. So it's not quite as good as the euploid embryo, but it's still better than the untested blastocyst. Now, these mosaic embryos have a slightly higher risk for miscarriage, but when they stick, they give you every bit a normal baby, as does your euploid embryos. So there was actually just a big study that looked at baby outcomes from transferred mosaic embryos, and they found APGAR scores same. They found milestones same. They found birth weights same. That kids grow at the same and do all the same things as normal kids do. So it typically gives you a normal baby. As long as it sticks, then it should be fine. So we don't want you putting two embryos in together, because that really does increase the risk for bad things happening to those embryos. If something were going to happen to the mosaic, which your body will normally be able to, or may normally be able to correct, if it doesn't, though, we don't want that to affect that euploid embryo. So I would not recommend doing those two things together. Let's see here. Annika Foster, is there a benefit for doing 90 days of suppression versus 60 with Lupron? Well, if you're talking about for embryo transfer, the data shows us that 60 days is really all you need. That 90 days is not better than 60, and that 180 is not better than 90. So if you can just do the 60 days, that should be sufficient for shutting down the endometriosis as far as the endometrium goes. Now, if you've got a chronic pain syndrome from your endometriosis, I would not expect that 60 days of suppression is enough to really make that endometriosis go away. We're talking about, strictly speaking, for fertility purposes. 60, I think, is all you need. Back to our friends over here on Facebook. Let's see, Michelle says, I got my meds today, mini bundle, because of the PCOS. So we dialed down the dose. Yep. I'm supposed to start cycle day 1 on Friday. I'm scared of possibly developing OHSS. What should I do, pardon me, or take to prevent it? Well, sorry, Michelle, you were given a lower dose because precisely because pardon me, we're trying to avoid that hyperstimulation syndrome. So I would be aware of the amount of electrolytes that you're consuming and the amount of protein. So if you get OHS, we say we push the electrolytes at about 200 grams of protein a day, which is a hard thing to do, but that may also have some preventative effect. If we believe that you have ovarian hyperstimulation syndrome, we will probably treat you with a medication that's called Dostanex or cabergoline. That medication is usually taken from the time of trigger for 8 days. And that has a preventive effect on letting that OHSS get out of hand. Now, OHSS is actually, in the grander scheme of things, is really pretty common. There are many practices that say, oh, it should never happen. But what we call stage 1 OHSS just means that you have big ovaries that are uncomfortable. Kind of when you move around, they create bloating and they create discomfort. And that's really a normal kind of part of the whole system, because ovaries are normally like this big. And so if we make them this big and then we do an egg retrieval, and every one of those little spaces fills with blood, then you have big bruised ovaries. And, you may feel that a little bit there. But the whole process is actually called controlled ovarian hyperstimulation, or COH. So we expect some degree of that to happen, but we watch pretty carefully because there's no reason that should be out of control. So you're in good hands, my friend. Flora says, my ovarian reserve came back at 0.53 and I'm 34. I was diagnosed with vitamin D deficiency. Could anything improve my ovarian reserve? Well, there are some things that may artificially lower your ovarian reserve. So if you had been on some hormone therapy before, like birth control, that can certainly be a reason. Endometriosis can lower that AMH. But when we talk about the number of eggs that are in the ovary, remember, you are born with all the eggs that you'll ever have. Kind of an unfair situation that the sperm that are produced or that come out today are produced in his body 3 months before they're ejaculated, whereas the eggs have been there since you yourself were in utero. And so over time, those eggs start to diminish, they start to go away, and the quality starts to go down. We can potentially do something for egg quality, as we talked about a little earlier, but we really can't do anything for egg quantity. At least not yet, maybe sometime in the future, but you're born with all the eggs that you'll ever have. And when they're gone, they're gone. So, but does that mean there's a bad thing there, Flora? No, with an AMH of 0.5, I expect we probably will be able to do pretty well with you as it pertains to doing IVF. The other thing to note, by the way, is that AMH, which we pay a lot of attention to, it's the number that I always want to know in folks, really does not correlate at all with your ability to get pregnant naturally. So I can't tell you the number of people I've had with very, very low ovarian reserves who maybe didn't do so well with IVF stimulation and then went on and got pregnant on their own. It's sort of like thumbing your nose at the whole system. So by all means, no reason to stop trying. Jillian asks, I have had 2 failed fully medicated FETs with euploid embryos, both failure to implant. I'm on immune protocol 2 with Prograf, which is good. Should we try something different or some additional testing? Blood work, sonos, HSG, saline sonos have all been normal. Okay, so the first thing I would say if we were on a call there, Jillian, is, all right, we had 2 euploid embryos that did not implant. So again, we're at an 88% probability that you should have been pregnant. And by the time you do the next embryo, you'll be at a 95%. But 2 embryos, gosh, I really want to know that there's nothing else going on there for you. These are both euploid embryos. So I'd want to know, when did you do your last saline sonogram? When was the uterine cavity last evaluated? A lot of times when I talk to folks, we find that the uterine cavity was last evaluated, 2 years ago. I want that uterine cavity evaluated every year. So if it hasn't been within the last 12 calendar months, I would suggest that you do that again. I do not think that you need to do another HSG. Next thing I would want to know is, do you take any supplements? Because there are 5 supplements that go along with the evidence-based protocol for embryo transfer. What are they? Your prenatal vitamin, vitamin D, vitamin E, CoQ10, and an amino acid called L-arginine. I would want you to be on all of those. Those are, by the way, we keep talking about supplements. All of that is available through Randy Fink MD's Instagram page. Link in the bio. Click that, and you will be able to get to where that list is. Okay, so those 5 things for sure I would want to know that you're on. Next, I would say, well, okay, we have to think about endometriosis. So certainly if that 3rd transfer took place and you didn't get pregnant, then I would be saying, all right, the classic wisdom here, the classic workup is hysteroscopy, laparoscopy. Why is that? Well, hysteroscopy, we want to know the cavity is normal. We talked about that. Laparoscopy, well, it's a surgery, where we put a camera in through your belly button to look around and see if you have endometriosis. Do you need to have surgery? No. We can do this non-invasively as well through a test known as Receptiva. If you're not familiar with Receptiva, they have a very nice website, receptivadx.com. And you can take a look at that. It's a non-invasive test, just a little endometrial biopsy that's done at a specific time during the cycle that shows us that you don't have the inflammatory marker in the lining that's associated with endometriosis. So those would be kind of the big things that I would say after having 2 transfers. Now, I would also want to take a look and say, well, all right, we did medicated cycles. Maybe we would want to think about doing a modified natural cycle. I am a fan of modified natural. The medicated cycle is where we are also called a programmed cycle, where we are giving you all of the hormones your body would otherwise make, and we are shutting down your body's ability to make it. So why do we do that? Because we can control every variable. When we do that, we are in charge, right? There's nothing left to chance. And that's the way embryo transfers have been done in IVF for 40 years. 85% of the cycles, embryo transfer cycles in the United States are indeed medicated cycles. The natural cycle uses your body's own hormones to do their thing. You're making those hormones anyway. They do their thing every other month. So why not let them take the front seat as it pertains to getting you pregnant? So in that situation, we either let you ovulate on your own, or we can induce ovulation. We can trigger the ovulation when the timing is right. So your body is basically making its own estrogen and its own progesterone. And that's a good thing, because even though the medicated and the natural cycles are said to be equivalent in terms of outcomes, there are some studies that show us that, in fact, the natural cycle may have a little higher pregnancy rate, may have a little lower miscarriage rate, and certainly does have a lower risk for certain pregnancy complications later on, specifically blood pressure type complications. So that said, it's also easier on your body. Your butt will thank you because you don't have to do the progesterone and oil shot. I would say it might be worth considering making a change there, Jillian. Sherry Ann says, I am age 40, fully medicated FET with Eupoid, failed last month. I had immune protocol 1. HSG and SIS were normal. Hormone levels were good. Uterine lining was a 13 the week before. Any suggestions next time? Well, so again, 5 supplements: prenatal vitamin, vitamin D, vitamin E, CoQ10, L-arginine. Generally speaking, we will usually use at least an immune level 2. Some people feel differently about that. There are many practices that don't do immune things at all, but that's one of the things that CNY is known for. So I would step up that immune protocol a little bit, but understand that even if you don't do anything else based on what you're describing to me here, Sherry Ann, you have an 88% chance of pregnancy with that next transfer. So fingers crossed. Does the cycle day matter, Latoya asks, when doing an FET in a medicated cycle? Well, no, not specifically. What matters in a medicated cycle is that we give you 6 to 12 days of estrogen. And that estrogen, it can be variable because we have the ability to do a little of this and that with the scheduling if you need to kind of get to a specific day. Um, 6 to 12 days of estrogen. The thing that is fixed is 6.5 days of progesterone, right? So it's typically 120 hours of progesterone. That part is fixed. And so whenever that happens to fall is when the transfer will come. But if we need to make that transfer on some certain date, we can take that date and then work back to 6.5 days of progesterone and then X number of days of estrogen in order to be able to get you there. So that's another benefit of the um, medicated cycle, that you have more control over the logistics. Latoya also asks, how is a hydrosalpinx diagnosed? Typically by ultrasound. It can also be diagnosed surgically or by MRI, but an ultrasound should be sensitive enough to diagnose any clinically significant hydrosalpinx or tube that's full of fluid. Rin Paquette asks, is there another drug like tacrolimus or Prograf that can be substituted? I cannot take that drug. That's interesting. And how important is it? Well, Prograf is a drug that is used to treat recurrent implantation failure. It is also used in our practice to try to prevent implantation failure. Is it a deal breaker? No, it is certainly not. As same can be said for any of the medications on our immune protocol. They are purely voluntary. They're recommendations. You can decide that you don't want to take them if you don't want to. But the purpose is to prevent the body from treating that pregnancy like an invader, like it was an organ that's being transplanted that the body's trying to reject. It's keeping you from trying to reject the pregnancy. Never seen somebody who can't take it, so I find that interesting. But if you can't do it, no, there's really no other medication that is as well studied as tacrolimus for that benefit. We've got just a couple more minutes here, so let's see if we can get in a few more questions from the Instagram side. Tara Whitmarsh asks, if we don't respond well to birth control, can we opt not to pause for retrieval in Colorado, preparing for another egg retrieval next month? Well, we don't have to use birth control for that. The pause that you're talking about, I believe, is that we generally ask folks to let us know on your cycle day 1. And then we schedule your baselines and your stim start. If the stim start schedule is full, meaning to say that there are already so many retrievals or stim starts scheduled, that is really to try to protect the embryology lab so that we're not doing 20 retrievals in a day, because that is just probably not safe for your embryos. Then we will put you on a little estrogen and progesterone. If you decide, no, I don't want to do that, then and the schedule is already full, you can always opt to wait until the subsequent month. The other way around that is to do a little bit of priming beforehand, which is something I like to do anyway, because it helps to juice up the ovaries, it helps to synchronize the growth of the eggs, and it helps to sensitize your pituitary gland. And that is from cycle day 21, in the cycle before you're going to start your IVF, we can put you on a little estrogen and progesterone for 10 days. And so doing, with that, we can schedule your stim start well in advance. Actually, since we know when cycle day 21 will be for that cycle, we can actually schedule your stim start with the very beginning of that cycle before. So that gives us a lot of flexibility. So Tara, that might be a good idea for you there as well. Shay Dunn says, my egg retrieval was yesterday and only 2 were collected and my right side ovaries responded to my medication. My MH is 0.9. Should I try another retrieval? Well, so, we only got 2 eggs there, I think is what you're saying, and only one side really responded. And that happens sometimes because of things like the blood supply that's going to the ovaries. Sometimes we'll really get a great response from one side and maybe even nothing from the other. Should you try again? I think with a little lower AMH, I always suggest that folks consider keeping it in their head that there's a possibility that they may want to do more than one cycle. Like it may take 3 cycles to get the number of eggs that's going to make you feel comfortable and confident that we're going to be able to get you a baby. So I would say yes, Shay. I think that would be probably a good plan. Now, I would want to have somebody take a look at your protocol, see if there's anything that we can do to tweak it to try to make things better. But I would say yes, if possible. It probably makes sense to do another retrieval there. Mrs. Carbonell, how can I ensure Dr. Fink is the doctor who can do my egg retrieval? I'm extremely sensitive and always get OHSS. Well, I'm here most days and most of the time right now, so I'll happily be here for you as long as I am able. Let's see, one more question from the CNY side. Amanda says, with Cooper not doing PGT testing in December, would you recommend doing a frozen transfer this month or doing a retrieval without testing? I'm 38, want to have kids, done 4 cycles, have 3 euploids. Well, Amanda, the question that I would ask is, well, how many kids do you want to have? Because if you are hoping to have 5 kids, then I think you want more than 3 euploid embryos, right? So, and at 38, let's say that we did an embryo transfer and you got pregnant. Oh gosh, that's great. What great news. Realistically, it's going to be another 1.5 years before you could do another retrieval. And at that point, there is a pretty significant difference in egg quality between 38 and, getting close to 40. So I would say that's really the question is how many kids would you want? And would the number of embryos that you have left, let's say you did 1 transfer and got pregnant, would that be satisfactory for you in terms of being able to build the rest of your family? Folks, we are at the top of the hour on this election day 2024. Sure am so honored that you were willing to spend a little time with me tonight. I have loved being here with you as every Tuesday at 4 o'clock Mountain Time and 6 on the East Coast. Every step forward with kindness, every step forward with love, because as we said, that is my hope for our country in the coming 4 years. There is too much anger. There is too much meanness. We have come to accept that that's normal, and we just have to say no. It's time to be nice to people, don't you think? Do something nice for somebody, even if they don't know that it was you. And most of all, every step forward with hope, because tomorrow is a new day. And whatever happened yesterday and whatever happened today, it's all just a memory, because tomorrow it starts anew. This is not the novel of your life. This is just a chapter. And what are we here to do? We are here to rewrite it together. So until next week, I am Fink. You are friends. Thanks so much for being here. Good night.